Welcome back to another episode of The Health Quest by Betty Okere. In the previous part, we were talking about thyroid disorders, and if I remember, Dr. was able to take us through the types of thyroid disorders that exist, why it is a problem in Kenya and in Africa in general, and basically just the signs and symptoms of knowing when I have hyper, when I have hypo. Of course, out of the knowing, we also need to ascertain that, and now that takes us back to the diagnosis part of it, Dr.
Yeah.
So as we start this second part of the thyroid disorders discussion, could you kindly help us understand what are some of the diagnoses that are done or diagnostic criteria for thyroid disorders in all the three categories that you mentioned earlier?
Oh, thank you, Betty, for that good question. I think in my previous episode, I had highlighted some of but now I'll put more emphasis on the specific test. You had asked about the thyroid function test.
Yes.
I had mentioned about doing the T3, T4, and the TSH. So now the doctor need to interpret those tests. They need to be done in a good lab.
Okay.
Because the problem we have out there, sometimes when you get the wrong lab, and that's the main challenge for the thyroid function test. Yeah, not all labs are empowered to do it. And as endocrinologists, we have maybe in the process of your practice able to identify this is a good lab. So sometimes we tell you don't go to this lab, go to this lab, not because I have an interest in that lab, because it has to be done in a very a lab where they actually check their quality control. Because remember, I have to make a decision about is it up, is it down, and the wrong test given to the doctor, I may make the wrong thing. So that has been the main challenge for us, identifying the good lab. So when you just request the doctor, where is the best lab to have it done? And don't go to some places where it's not, And it's not surprised when the doctor tells you, fine, you brought this test, can we have them redone? Because the doctor has to make some decision. Because there's some certain way I know a good doctor is able to interpret. Is it hypo? Is it hyper? Is it normal? Because the range, the lab is going to give the range, yeah? So when it's hypo, I expect the T3 and the T4, or either of them, to be on the lower side.
Okay.
Reduced. But the TSH, remember the TSH, it is
the thyroid stimulating
is the one which stimulates the production. So when your thyroid gland is underactive, it's not producing, there are some messages which are sent, we call it as positive feedback to your brain. The pituitary gland is being told, here, I need some more. So what happens, the pituitary gland becomes now more hyperactive to produce more TSH, so that TSH can work more on the gland to normalize your thyroid hormones. So when you have a shortage, you call for help. Please, I need. So either the factory to now produce more, because they already sense on the normal with the normal TSH, the supply is not as good. So to compensate that, you need the factory to be more, to work more on them, so to maintain the thyroid hormones at a particular pace, so that your body functions continue working. So another gland has to work on excess, so now to maintain your body.
So if I get you clearly, Dr. You're trying to say that if I run the TSH test and I find that my levels for the thyroid stimulating hormone, the TSH, are higher, it might actually mean that my body requires more, so I am.
So you have hypothyroidism. So it's a compensatory mechanism.
Okay.
So a good doctor is supposed to know that. So that's why the lab is very important. So when I see this is up, that tells me the story. This is working towards. So this is maybe the time I'm doing those thyroid function tests, the TSH may be the one which is high, but it has stabilized the T3, T4. So they're within the normal, but I can see this is up. That tells me that there's a condition called subclinical hypothyroidism. The patient is not even symptomatic. That's why now TSH is used for screening. Because maybe when your T4, T3, they are within the normal, because the body has
has
there's a
compensated
compensated
for that.
So that's for
absence.
subclinical. So where the T3, T4 may be normal, but the TSH is high. Okay. Sometimes even despite the compensation, it has worked hard, but the thyroid gland is not working for whatever reason that you've talked about. Let's say, for example, you don't have the thyroid gland. So even if your body is sensing you don't have, and it's a feedback mechanism to produce more TSH, but what is it working on? So your T3, T4 remains down despite a CSH being so
high.
you find now an overt hypothyroidism where now TSH is up, but now your T3, T4, they're down.
Lower.
So that's why hypothyroidism. Okay? Yes. Now the opposite may tell the story. A gland that is acting itself is working excessively. It sends a negative feedback. Close the factory. I've had enough. I'm producing enough by my. Remember that thyroid is working autonomously, not with the others. So it's not working in tandem with the pituitary gland. It's hyperactive, whatever reason you've talked about. So it's not the normal business as usual. It is whatever reason has made it to be hyperactive. It is not responding to the
feedback it's
so now so this one, what does it do? It now sends, I have enough,
I'm self-sufficient.
Actually,
I have excess.
Just like you have excess money, I just tell me, please don't send me more.
I do not have excess money for the record.
So this one tells the up there's like, please, I have enough. So stop the factory of TSH. I'm already. So now what the effects? T3, T4.
Very high.
Then what happens to T3? TSH
is lower. Wow.
Okay. And sometimes maybe the compensatory mechanism has happened, so the TSH has been dropped to a level now that has stabilized there. So you have a normal a low TSH, T3, T4 normal. That's called now a subclinical. Hyper. No, this is the opposite.
No, that's opposite. Yes, hyperthyroidism. Subclinical hyperthyroidism. Okay.
Yes. When the thyroid hormones are done and they're within the normal, that's called euthyroidism. They're within the normal.
Okay.
So this one maybe you already have the goiter, but the function is okay. Or maybe we can use it. The TSH we still use it for monitoring treatment. Let's say you've already diagnosed you with hyperthyroidism or hypothyroidism, and you've put you on the appropriate treatment, as I'm going to talk later, then I'll still need to do those thyroid function tests to tell me how to adjust your treatment. Because again, the thyroid disease is most people it can stay there for long. So I need to monitor so that this drug is not a fixed dose. So I may put you on those drugs, then they suppress your production, then I don't want to have another. So it's not getting a balance. So the doctor need guidance of the thyroid function test to know, do I increase the dose? Do I lower the dose? So I may start at a particular dose, subsequent, you can be given a month or 2 months, come with another thyroid function test, let's see how you're doing. Or this dose, let's reduce the dose. So you may use those tests for. So when you get the thyroid disease, be ready to be requested for several of those tests. Especially every visit, the doctor needs to make adjustments, so it can be quite expensive to treat thyroid disease.
Don't worry, we will talk about the cost effectiveness of this later on before we finish the show. Okay. But I take you back to diagnostic criteria. So if I recap, what I have understood from you is that we can use the TSH for screening. However, it will also help us because it will inform whether somebody is hypo or hyper. And then we look at the other thyroid functions, the T3 and the T4 hormones, to determine which side of it we are at, and even if we have goiter. And of course, iodine tests to determine if we have deficiency or not. So that's one way. The thyroid function test is one way of diagnosis.
For diagnosing and monitoring.
And monitoring.
So there are two functions. Okay. So monitoring somebody already on treatment or for diagnosis. And adjusting treatment, and the doctor will advise you when to stop the treatment. So some diseases you may stop.
You may end up stopping the treatment.
Or you give the lowest dose possible.
For maintenance.
For maintenance.
Okay.
Now,
so which other diagnostic criteria?
The other tests that we may need, I'd mentioned before. The one, remember when I told you the YouTube? The fine need
but you can mention it, yes.
That's called the FNA.
Yes.
Where the doctor now, you have to go to the hospital, some labs where they need a pathologist. So a needle, you see now you already have this done when the goiter is, the thyroid gland is enlarged. It can be done directly, or sometimes you need an ultrasound guided FNA. Because sometimes it's a bit small, or maybe they want to be sure of where, maybe it's a nodule, they want to specify a nodule. So an ultrasound guidance.
Wait first.
Yeah.
So we are doing an ultrasound, and you're saying fine needle aspiration.
Yeah.
So, in other words, there is a needle that is going through.
Yeah. But now the doctor is being this. The ultrasound by itself is a diagnosis. By itself, even without the.
Yes.
But sometimes you want to combine. So there's some, the thyroid gland is so big, you don't need a help of an ultrasound. So the doctor will just take the needle, the preparation. It's just a painless. You don't even need to be taken to theater.
A needle that is painless.
If it's pain, there will be minimum. I've done it before, and I've asked the patient, was it easy? And don't even need to be put at local anesthesia. But some people who are so near, they may spray a bit of. But just as a fine, when you say fine needle, fine means what?
Very small.
Small. It's not those needles that inject animals.
Be encouraged. Be encouraged. She is confirming that it is not painful. But don't worry, we will also talk to another person to
minimum pain.
Yeah.
So is put now straight to where the swelling is, and whatever inside this aspirated
can be pulled out.
Yeah, pulled out. Then it's spread on a slide, glass slide. I don't know, those one who did my biology. It's so hard to be basic with science, So whatever material is removed from that is spread on a piece of glass, which is now be looked for, it to be prepared. The people in the lab, they know how to do the preparation. Then under a microscope. Microscope, you also don't know what is a microscope.
No. At least we have an idea what a microscope is, and of course we can show you a picture.
So somebody who has been trained on that is able to look at whatever the product is and tell us what are the cells in that. Is there a cancer? Because that FNA helps us also to pick a cancer. Or maybe remember some of the nodules, they don't have a cancer, but you tell us which cells, because there are different cells in them. In the thyroid gland, is it the follicular cells, or which types of cells are there? So it describe the cells about that, and it can help us to make a decision about it. Okay, then an ultrasound. An ultrasound. I know most of you have done an ultrasound for whatever reason. Maybe the ultrasound you're done for women when you have a baby. So it's non-invasive, just a probe. Which is just put there. The doctor through the computer is able to have a view of inside an organ, not directly, but those are technical terms. So they're able to view whatever the part of the body. So an ultrasound can be done any part of your body. So when you can be done in the breast, you can be done even the chest. Those are. So now the one for the thyroid, again, it's not everybody who has been trained to do an ultrasound. So again, your doctor will guide you. The best people who have done it, there are people who are dedicated. There's some radiologists who have now extra training on the thyroid. So again, it's not everybody who is able to, because they have the way they have been taught. This is where you look. This is how they can even give the grade. If there's a cancer, they know this is how a cancer looks like. So again, it can be done an ultrasound by somebody who is not trained on special. That's a special ultrasound. So it's not everybody who is empowered to do that. So your doctor will guide you. I want this ultrasound to be done by most of the time, maybe sometimes you prefer a radiologist. Or is a sonographer, then it's a sonographer who has been specialized in the thyroid disease. Because again, remember, as doctors, we rely on the report given. So if a wrong report is given to you, then the doctor may make So that's why we are specific. Please go and do this ultrasound in this place. Sometimes we wonder, why are you telling me to do it? But because I know if you bring me from this, I've worked with this person, I know they're trained with that. So I'm able to make a decision. So that the ultrasound is very important.
And that calls for a lot of trust, because I know sometimes the patients will say, I know somebody else who can do it cheaper.
Cheaper. So so you come with an ultrasound and the doctor tells you, please, whatever they have reported it
is not in tandem with what I've
it's not
seen
in tandem. Because there's somebody who is able to say this is a cancer. They're able even to go to do the whole neck ultrasound. And sometimes you have maybe a thyroid cancer which is spread to the nodes around. So you can imagine it was done with somebody who doesn't know this is a cancer.
Then you're not able to catch it early and you can't treat it, and you probably now succumb to
you
the
succumb
cancer
to your illness.
for things you'd have prevented.
People have mentioned that disease called the Graves' disease, which is an autoimmune, so your body is very active. So there's a special test which can be taken, the thyroid scan. This is not the ultrasound. This is a scan where they use radioisotope. Is there a better...
Trust me, I do not know a better word for radioisotopes, but just we can Google that later.
So they put some iodine, what is this? Those cardiolabeled, whatever. So it's a special test.
There's a special thing that is put.
So now is when it's put through your vein. So it's going to, it contains.
It's like a coloring matter.
Yeah, coloring matter. Which now it is very specific for the thyroid gland because it has some iodine. And remember, iodine is only uptaken in the thyroid gland. So that makes it a very special test because whatever you injected is not going to go anywhere in your body. So it is go to the thyroid gland, then using that special scan, they're able to see areas where you are. So if there are people who have been trained how to do it, they're able to know this is a very active thyroid gland.
Or not.
So it can be the whole of it is showing, or maybe if it's a nodule, it's able to show this is just one nodule which is very active. So it helps us to so the thyroid scan. So those are some of the tests that can be done. Of course, you need other supporting tests, maybe because you're going to put this patient on treatment. So things like hemogram, checking chest X-ray. So the other tests, or even an echo where the doctor feels maybe the thyroid gland has affected your heart, and maybe I need to know whether your heart is okay. An ECG can be done. So the other supportive tests but those are the ones specific for the thyroid gland. There's sometimes you may be required to do a CT scan of the neck, especially when you're talking about a cancer or an MRI of the neck. So those are now, the doctor will guide you. Those are not universal.
Which tests
but the three basic tests which majority of patients with thyroid disease are thyroid ultrasound, TFTs, which is a thyroid function test, and maybe an FNA when you have a nodule, and some of the goiters may need an FNA. So an FNA again is not for everybody because you don't have a thyroid enlargement. What are they doing? Nothing.
Yeah. And how easy is it to have these tests done in Kenya?
With this, you see, previously we didn't have enough endocrinologists, and now we are quite a number. So now most labs have introduced the thyroid function test, but the challenge you have is the cost. The cost is a challenge, and also having a good lab that is able to give you. So there's some labs which are still not giving us good, but you, as endocrinologist, we have been identifying. So when you are when you're told to repeat a test, just take it in a positive way, because it means a lot, and the doctor doesn't want to give you, because now treating, you don't want to be treated for the opposite. Let's say you have hyperthyroidism,
then you're being treated
and the
for
tests have shown me the opposite. Then I pump more thyroid hormones to you. And
it is even going to make the condition worse.
And you have seen things happening like that. And you go there and you're like, oh my God, your face, your eyes pop just, and you're like, you don't to the patient, but you're like, well, I'm shit.
But even as you're saying that, the reality of the matter is that some of these labs and tests are only available probably in the major cities. You see, now that's a problem. Because this disease, I'm sure, does not choose.
So we create more awareness for patients, creating more awareness, even among us as doctors. Especially like when you talk about clinical officers, the nurses, the medical officers. So some of them, they're not aware about this disease, so they may not even request.
They may not be able to pick it.
And again, the interpretation, my goodness, the things you think they are just basic, then somebody interprets the opposite and does the opposite. I've seen that a lot.
Wow.
Yeah.
You have been mentioning women. And I'm actually just thinking, and I'm sure even the audience is imagining, this thyroid disorder, is it just a problem that is to do with women, or does it affect men as well?
They affect men also. But you know, there's some diseases which are more frequent in women. When you talk about autoimmune disease in general, those those diseases that have antibodies, they are more frequent in females. Maybe
Females
something
and
to do with their
males.
hormones, I don't know. But they are more common in females. So thyroid disease maybe there's a higher
More
prevalence
inclined
in
to the
there.
population
But
of women.
men also get even thyroid cancers and stuff. So it's not a disease restricted to one gender, but the women has a bit more higher prevalence because of the autoimmune aspect, which is more prevalent in males, in females,
than
versus,
in males.
versus males. Yeah.
But what you're trying to say is that all of us just needs to be checked.
There's nobody who is immune to it. It's not like the way you have cancer of the cervix. A man cannot have cancer of the cervix.
Of course.
But these are now everybody can get it.
Whoa! Wow! Treatment.
Wow.
Treatment. What do you have to say about treatment? Is it accessible? What sort of treatments are we looking at? Do those treatments have any side effects? Could a treatment of thyroid disorder actually cause me another disease? Because again, we want to be safe by all means.
So when the specific diagnosis has been made, first we classify, is it hyper? Is it issues about obstruction? Somebody come with the obstruction, thyroid hormones are okay. We work together, especially with the ENT surgeon.
What is ENT?
ENT is
the ear,
these are specialized surgeons who now they deal with the E means what?
Ear.
Oh, ear is what?
Yes.
What is the ear?
Ear.
This. Oh.
Ear. Nose.
Oh, this one. Yeah. Nose and the throat. Yeah. So the thyroid is just around the throat area. So they are more. They are being in their training. They are being trained to do surgeries around the neck. But even the general surgeons can be able to. They also taught that. So the general surgeon and the ENT, somebody may choose depending on which hospitals you're working. There's some hospital who have a policy. This is for ENT, but there's some who even a general surgeon can do. Out there are people who specialize with endocrine surgery. Or even subspecialized, they don't operate anywhere in your body. They just be doing the thyroid surgery. So I think where things we are not yet there. We are not sub specialized.
I've actually seen people who are just interested in the head and neck.
Yeah,
and that's all.
That's it. So depending on where people are working, then you can go to that person. So you can find somebody who now they work every day. They wake up is a thyroid. That's somebody who will be so good.
Subspecialization.
Somebody will be so good. So those hospitals, you find there are people who would say, "Oh, I'm going to India." And may find maybe they have those areas where they have those subspeciality that everybody, you're waking up the thyroid, You'll be more refined than somebody who today is operating the nose, the other day is operating the ear. So more, but they're still in Kenya we use the ENT or the general surgeon. So whichever doctor you're sent to, then maybe know the kind of hospitals and maybe do background check, what are the outcomes and stuff. Because again, the surgery, it comes with the side effects. I mean, some complication may happen. I mean, any surgery, even you had been told, I'm removing your battle like this. And that's why most of the time before you go to theater, there's a consent.
There's a consent.
And you're told these are. So what are some of the things may happen? Of course, the common thing may happen, the anesthetic accident, just like any other surgery, is not safe, okay? But if the hospital has, and the doctors are well trained, we cannot say we cannot go to theater because somebody else, this is what happened, but you have to be aware about the risk. Then remember, we are removing the thyroid gland. There's some surgery which require the whole of the thyroid gland is removed. But there's some who can, maybe depending on whatever it is, you can have a partial thyroidectomy. It's only part of it. So you still remain with your thyroid gland, which is still producing its hormones. But now a situation where the whole thyroid gland has to come out, you have now a situation where you're not be able to provide. So what do you do in that? So after surgery, you need long-term follow-up, where now you have to be given hormone replacement therapy, where you're now getting. Remember that T4 you're talking about? Yes. That drug is the levothyroxine is a T4 replacement, because T4 is a hormone which will be converted to the T3. So we don't use the T3. It is a celeb. Yeah, the T3 is the most active. So the T4 is a bit slow. It will be broken down to be converted from T3 to T4. So that's why now the replacement, we use the levothyroxine, which is a T4. To replace. In very few occasions, some T3 or a combination of T3, T4, but that is for specialized care. I don't want to go that level. Okay. Then there's very interesting, when you talk about the thyroid gland, there's another gland which is not thyroid. They're called parathyroid.
Parathyroid hormone.
Para means what? Parallel.
Or behind. It's like when we say paralegal, we're not talking about a lawyer. We're talking about somebody who has special training in law.
In this case, I'm not going to.
Is it the same?
No. In this case, because we have talked about this thyroid gland which is here. Behind it, there are some glands which are behind it. They are unrelated to the thyroid gland, but they are. It's like it's attaching to it.
To the thyroid.
So these are called parathyroid. They are not the thyroid, but they're parallel to. I think there's a
parallel to the thyroid.
Yeah, but they're not thyroid, and they have no function of it. So remember, when you're removing out the thyroid gland, those glands, they also, because they are attached, they are not related to the thyroid. Actually, their work is to produce a hormone called parathyroid hormone, which its function is to control the calcium metabolism affected when you have issues about the calcium. So very unrelated. But now when you remove the thyroid gland and you remove together with those ones, you create another problem. Apart from the thyroid gland not producing its own hormones, you have also removed, and there are usually four behind, okay? Although some people may have three, whatever it is, yeah? So you create another situation where a patient does not have now the parathyroid hormone, a special hormone for calcium
metabolism.
And you have seen cases where the doctor just removed it and did not tell the patient they need now. Now you get now long-term follow-up.
There has to
with
be
your
calcium supplementation.
So you get calcium supplementation.
Hello, my name is Betty Okere, a clinical dietitian and diabetes educator. I'd like to talk about micronutrients. Micronutrients refers to nutrients that either are vitamins in form, minerals, or trace elements. These nutrients are required by our body in very minute amounts. However, if we lack these nutrients, then we get what we refer to as micronutrient deficiencies. Food processing, like fortification, have become very handy in ensuring that populations at risk of micronutrient deficiencies can actually be able to receive these nutrients. Such a product is Brookside Plus fortified vitamin A and D whole milk. Essentially, we are able to support the immune system with this vitamin. We are able to enjoy good vision, and the vitamin D will come in very handy for your bone health and teeth health. When we heat this milk, we do not destroy the vitamins A and D because they are essentially not destroyed by heat. The presence of fat in the milk will also help us to be able to absorb the vitamins because vitamin A and D are fat-soluble vitamins. Or does it mean they have to drink more milk? Can they drink sufficient milk?
No. In this case, because if you don't have enough calcium, what happens? The body compensates by looking for calcium elsewhere. And calcium is stored where? In the bones.
In the bones.
So your bones become weak. Because the body is like, and see, the body has to be maintained, the calcium levels have to be maintained because they control the contraction of the muscles, the heart. So you don't have enough, the body is decided, okay, the bone is just chilling there. It's not an essential organ. Kind of at that particular time, so it can donate. So you get now problems. You started with the thyroid. After surgery, you end up now getting in the bone because if somebody did not, because the calcium, or you come with very severe hypocalcemia, very low calcium, and people come with convulsions and can go into coma because you do, or your body is in very stiff because it cannot contract because you don't have enough calcium.
And you see now when the calcium is affected, then there's the issue of vitamin D.
Yeah,
it's a whole web,
cascade.
it's a network.
So you see, that's why a very good doctor has to know. After surgery, you're told, can you be checking your calcium? And that's a very common problem you have. Where if the surgeon is not keen on, or yourself, you didn't follow the instruction, now we see people coming with issues about the calcium being very low.
Or you probably just started feeling, oh, I think my bones are aching. And
Yeah.
all that. I think I need vitamin D.
Yeah.
You go over the counter and
Yeah,
buy for
yeah, you
yourself.
buy,
You take
yeah,
your calcium.
yeah, and you don't know what's
so you
happening.
actually need
So
to
it's
check.
a very low. It's not some of the side effects, or maybe the surgery during the surgery. Remember, these are very sensitive area. Their nerves there, so somebody can maybe injure a nerve, which control your voice. So people who get
I see.
voice.
That shouldn't happen.
So somebody who was clear is like, oh, the recurrent laryngeal nerve has been injured, then your voice is hoarse. So it's like, what did you do? So those are, but now a good surgeon. That's why I say you have to know which surgery is doing you. So they're able to know this is where the nerve goes. So they're very careful not to injure.
Very
because
delicate.
if it's injured, you can. It's a very. But I'm not saying this to scare you. Those are facts.
Yes.
Because again, if you don't operate and you're already getting obstruction, unanyongwa.
You cannot even swallow
Can't
your food.
Eat. So you take in life. Sometimes you take risks. Yeah.
You just have to know which
you have to check
calculated risks.
Yeah.
And you look at the gain at the end of it all.
Yeah. So surgery is one of the things. Yeah. Then, depending whether if you have hyperthyroidism, you're given anti-thyroid medication, drug to stop your
thyroid
gland
from
being
overproducing the thyroid hormone.
And you have drugs like carbimazole. Out there they use the methimazole. They're the same drug. Carbimazole is like a pro drug to be converted. There's some like places like the US, they use the methimazole, which is already an active drug, where carbimazole is a product to be converted. So depending on which country, but in Kenya it's carbimazole. So that is the commonest anti-thyroid drug we use. And it can be, the challenge is when somebody is pregnant, we cannot use. Okay, so what is the other anti-thyroid gland we use, especially in pregnancy, is called propylthiouracil or PTU.
Pro who?
That one. Propylthiouracil. But
Propylthiouracil.
PTU. Okay.
Yes.
So it's safe in pregnancy. The challenge is quite a bit expensive. So that's why you need, if it's a female who is pregnant, we really, now you need to know when to change. And most of the time when somebody is pregnant, we try to, can you maybe avoid becoming pregnant? Let's handle one thing at a time. Because when you're managing a pregnant lady, so you have to think about the mother and the child. Because anything you're doing is affecting the child.
So even the medication have to be safe for
so that's why you have to work together with the obstetrician, a pediatrician, because the child can be born with effects of the drugs. So it's when I see a woman in a so for doctors who you treat, please, when a female is at reproductive age, please ask them, are you on any contraceptive? So maybe avoid becoming pregnant at this time you are treating, because that's become an issue. But who are we as women? We just our life must go on. So despite that, you find somebody.
It is God's
command. I know. So the next clinic visit, doctor, I think I'm pregnant. So you have to really, discussions about pregnancy has to be discussed for female in reproductive age. Are you pregnant? Are you on any birth control that like for now let's deal with one. But the minute the woman is now pregnant, that's now we have to deal with that. Because even the way you monitor those thyroid function tests, they're a bit different from for the women pregnant. They're very a bit strict. The cutoff are even different because we don't any to control the thyroid gland to an extent. The child is also getting hypothyroid because congenital hypothyroidism can cause even mental retardation. Mtoto anazaliwa hana nini?
They can't.
That doctor can never be a doctor. That child.
I know.
They can be born with that big tongue.
No way.
It's bad. It can be bad in pregnancy. So that's why it becomes a bit. So you need to be. So that mother has to be really followed up by.
And actually, what I'm thinking about is that then when these decisions are being made, then we also need mental health support.
Yeah.
Because how do you just wake up one morning, you have just gotten married and you have this condition, and then you're being told you can't have children?
No, we don't have. We cannot have children, but it's a discussion which has to be put on the table.
If you must have children, then these are the risks.
Or maybe let's first control you. Then it should be now a planned pregnancy where now the TSH, there's a cutoff. When can we now? This year TSH is okay. Now it's safe to, it's clear. Then I remember if you're on some certain drug, like say you're already on carbimazole, I have to remember now I need to change you because the first 3 months is where embryogenesis, the body the body is being formed. So anything that can affect the baby it's the first 3 months. So you really you don't use a drug that will affect the unborn child. So now you need to change that patient too. So once you tell me, yes, I want to become a mother. So I mean, there's nothing much I can do because this is what nature tells you. Yes. But I have to tell you, now we need to stop carbimazole. Even before, I need to have, that's why I need that pregnancy to be planned.
It has to be a planned pregnancy.
So now I tell you.
No oops moment.
Yeah. So now I can say, now stop the carbimazole, let's start you with PT. Not that when you become pregnant, remember by the time you're missing your first period, that baby is there for?
Some 2-3 weeks.
Yeah.
Actually 3 weeks.
A month or so. So the next.
So 1 month is already lapsed.
From 2 weeks, yeah. So that the child is already. Are you getting that? Yes. So we cannot wait for you to say, now I'm pregnant. Now it starts changing. We plan before. You're like, okay. Yes.
I'm planning to get pregnant.
So that discussion has to be put on the table. How many children are you married? How many children do you have? Are you in a birth control? Okay. So now we put the right treatment from the word go. So I don't want to change it when it's too late.
Wow.
So that is not. So the PT is now used as that. Now. Outside pregnancy, even surgery can be done during pregnancy. This is obstruct, but avoid it during the first trimester. So it has to be again coordinated. When is the best time for surgery? So yes, it can be done because it is okay. It can be done, but of course preparation has to be done. It has to be done in very special units where, okay. Now, what is the other concern? The other way of managing. Yes. We can use the radioiodine, radioactive
iodine.
Yes. So this is now, this is for women. You're not planning to have a pregnancy. It's contraindicated. You cannot get.
You cannot do radioactive.
Yes.
So if I do it and I didn't have children, it means I can
never. Not.
Oh, okay.
There's a time frame.
Okay.
So you have to have planned like this one, no pregnancy. Okay. Sometimes even let's say, what is it? It's so you are injected that iodine, isotope. So this is not for diagnostic. So you talk about the radioiodine being used for therapy, radioiodine therapy. Yes. Okay, so it's injected in special hospital where they already have that facility. So it goes now. It's be uptaken by the thyroid gland. So it burns it. If I use the layman terms, ablation. It ablates. So it's an alternative to surgery, but it's going to cause now your thyroid gland now to be like, now it's gone. It may be physically there, but it's no longer.
But it's no longer functioning.
It has been banned. I'm a banned.
I didn't know we were going to use that word.
So now, so it ablates. And we don't use medical terms. I don't know. So it's like that, but you get the gist. The whole thing is to tell you these are the other methods of. So maybe these are for people who maybe they're not fit for surgery or they opt to
older
use
persons?
it. Not necessarily.
Okay.
Or maybe you have used the antithyroid gland. I mean the whole medication, and they're not working.
They're not working.
So now you need second plan. So either surgery or radioactive. But before you do that radioactive, you have to be checked your eyes because you have the thyroid eye disease. You cannot be done. So it's you have to involve the ophthalmologist.
What would happen to my eyes?
It's not recommended if you already like so you have the Graves' disease and you already have the thyroid. Remember I told you that eyes that is popping out. So we don't use the radioiodine active thyroid disease. So that's what I'm saying. You need is a multidisciplinary disease. Ophthalmologist is on board. We have the surgeon, either the ENT. An endocrinologist is on board. Okay, so it's quite
While on that, and I think this now moves us to the next part, which is the public. Already we are talking about multidisciplinary engagement of specialized, highly specialized medical personnel. How affordable is this? Who has the money?
Yeah, and you find now, like you go there and you find now a clinic officer dealing with the thyroid disease, and maybe they have not understood how to, or a NEMO who is not trained, and sometimes they really get a mess. So the much you can do, if you have a physician, the patient should be under follow-up under a physician. For children, of course, and a pediatrician.
Pediatrician.
Or if you have now an endocrinologist like Dr. Wairagu and my colleague, then that patient can be sent there, because now they have a bit more of understanding than
what
to do. Because now that sometimes need long-term follow-up.
On average, if I'm talking about an adult and you need an endocrinologist, you will need a surgeon, because maybe surgery is the way to go. Before that surgery, you need medication. You need an ophthalmologist to make sure you're okay. How much are we talking about?
Are you talking about Nairobi Hospital or Kiambu? It depends.
Whoa. So if I'm in Nairobi and I need specializing...
I mean you can get that. I don't want to give a figure, but you can see. And these TFTs, they can be quite expensive. So the least, I think the lowest I've seen is maybe 1,800 Kenya shillings or 2,000. This is in most public hospitals. But now when you go now to high-level labs, it's 7,000 and above for doing those TFTs.
Wow.
Yeah. So when you can now say the ultrasound, the FNA, things can be quite expensive.
Does the public know? Because I'm thinking, if you're able to diagnose somebody when it is still in early stages, then treatment might not be that expensive. Does the public know? Is there anything we are doing as a community of medical practitioners, doctors? Is there anything we're doing to inform the public about
like
this?
what you're doing? I mean, awareness.
I just need it.
I know there's somebody here who didn't know about it. Even our camera people, I know they did.
I think they're going to pay consultation after this.
Not this, I never. So you can I mean, you're in the space, you're doing it. So you can have now people going machinani to vernacular, people talking about it, having medical camps talking about it, and then the screening for the people, maybe a TSH even for people with maybe a risk, then we're able to do the follow-up.
Is there
training more doctors, having more endocrinologists being trained on that, training more surgeons, training more ENT, training the radiologists on how to do the...
Maybe we're training everybody and then everybody's leaving.
I don't want to be political now.
Let's leave it. But that's the truth, because then ideally, so you train. I come from rural Western, and I'll come to Nairobi because that's
doctors always have to look where their needs are taken care of. So
that's a sad reality. So what would you advise somebody, to our listeners? What would you advise them? What do I need to do to just keep myself safe? Is there anything I can do to prevent it? Is there some foods I need to eat? I don't ask me to respond to that.
You're the nutritionist. That one is.
We'll get somebody else to take care of that. But is there anything I need to do just to...
We've talked about this. So of course there's something, but sorry for cutting you short. There's something you can do to some extent, but there's sometimes there's nothing much you can do to some extent. Assuming your head that is genetic. And autoimmunity just happened. How do you prevent that? Are you getting that? But you have control of, like, am I eating iodine salt? Okay? Maybe the government, using the Ministry of Agriculture, they can be able to do the soil analysis and they know these people are deficient, maybe supplement more. Pregnant women being more taken care of, where they're deficient, they can get supplementation of iodine before they have a problem. So yes and no, whether there's something you can do. But the awareness, I think, is a major thing for both the public and also the healthcare providers. So
we actually have to talk about it. And I'm just thinking, even as healthcare providers, be able to educate each other. You're an endocrinologist. Be able to, you know, when we go for all these conferences, talk about it. Let other people know. Let us now actively search for these things, and we could just save lives. And even sometimes you actually live with a condition, but at the end of the day, you don't have quality years, because then a condition is keeping you down for something that would have been managed much earlier and given you a better...
When you're hyperthyroid and your moods, you're down, and is that good quality of life? You're depressed, basically you're in depression throughout. When you're hyper and your family is broken down, what do you do?
And you're breaking everybody along the way. You're like hurricane, passing with everything along
from
the way.
Neighbors, oh my goodness, that's nobody just. And when I've seen maybe that irritability. When you start the patient the treatment, the family come in to apologize to the patient.
We didn't know this is what you're suffering from.
Yes, I've seen now. They're like they have seen some change in their mother or their father, and now they want to come and see who is this doctor who
has performed miracles.
I've seen that. Where now they're like my mother, and they come and now they feel, they already guilt trip because they had already, I was up group discussing your mother. Discussing your mother.
There's a purpose for discussing the mother.
Jen, I went to visit mom. Have you talked to mom of late?
And they're like, no, don't even call her. By the way, if you need peace, don't
go there. So now when you start the treatment and now you have controlled the hormone levels and the person is back to themselves and then maybe they're able now to tell the children, I was diagnosed with this. And they're like, wait a minute. Then they have noted the change in their... And then they become now
accommodating.
Now they become curious. What is this disease that made our mother to be? And then there are people who become so crazy and even they're taken to a mental hospital.
To treat.
There are people who are even picked from a therapy because you become, you're hyper. You're beating people. You can even beat people, and people think umeruka kichwa. So unajipata umeshikwa na polisi umepelekwa Madhare. There are people in mental hospital because of thyroid disease. So we also work with the psychiatry to be able to know this is not a mental illness, is a medical illness that is causing a psychiatric
treatment.
Yeah, so I've seen families come in there, okay, so sorry, mom. And they
and of course that is an awareness even to the family as they come, because if it's genetic, and now you have been able to treat it, you now start checking earlier.
You even start peeping at them whether they have. It's one of the most dramatic diseases I know I treat, especially when it's hyper. Hyper, they just a mood they're going to elevate, but the hyper where somebody was high and you're able to put the right treatment.
You're making me overthink now.
That palpitation, the sweating is over, and the person come and they're so calm. It's like kurusha sufuria.
And the palpitations and all the sweating can actually be confused if it's in women and older women. You can actually confuse it for menopause.
Yeah. So that's just great. So you have even excessive sweating. You have those hot flashes. So it's you have to really differentiate, because the hot flashes will come episodic. Again, when you're menopause, you are irritable. Again,
women, it is an extreme spot to be a woman.
So before we say this is menopause symptoms, can you also be checking for thyroid disease? Somebody coming with a depression, coming with irritability, they're just telling you, I'm not feeling okay. Wow. I'm just feeling tired. Don't assume everything is menopause. I know you'll be having a topic on menopause. Because if we have said menopause, somebody's like, what is that?
Yes,
so I don't know. I don't want to preempt, but I think
yes.
it's one of the topics that I think, again, because again, you've seen the overlap of symptoms.
Yes.
So you cannot, there's some diseases you may not say these are obvious thyroid disease. There are people who, in the first presentation, they come with a heart failure. Because that heart has been beating so much.
Overworking.
It has overworked. So the first presentation patient is in heart failure. So until you know, this heart failure is not, the heart was okay until the thyroid
something else made it
something
fail.
Came. Yeah, so again, there's a overlap of disease.
Wow. I can tell you one thing. When we start discussing health issues, when we start discussing health matters, we can never conclusively get to the end of it all. But I am so sure you have learned so much more from this episode, and we thank our beautiful and very informed Dr. Anne Wairagu, for that very good discussion. Thank you so much. I think that is all we are able to discuss in this episode, and we still accept your feedback and any other comment that you may want to give us to make this program better for you. From us here, it is bye-bye for now. Until next time.
Bye.